name is Erin Bishop, and today I will be talking to you about the presenting symptoms, treatment, prevention, and ocular effects of infective endocarditis. Infective endocarditis, also known as bacterial endocarditis, is a condition in which bacterial organisms invade the host blood and circulate to the heart, where they may reside in the heart's valves, endocardial surface, or blood vessels. Staphylococcus bacteria and other gram-positive bacteria such as Streptococcus and Enterococcus are often the culprits for infection. These bacteria can enter the body via cutaneous, portal, or digestive surfaces. Once the heart's been inhabited by the bacteria, they can cause an inflammatory cell influx and lesions known as vegetations. These vegetations have the potential to cause an array of things such as embolisms, damaged endothelium valves, and regurgitation. Lesions on the heart's valves or surface prevent host immune cells from defending against pathogens and therefore leave the heart vulnerable to various complications. Just to name a few of these, there could be valve destruction, embolism of various blood vessels, metastasizing of infection in specific organs, or some kind of phenomena such as false positive rheumatoid factor. In the picture to the right, we can see some of the vegetations on the valves of the heart. So who exactly is at risk for this condition? On the whole, infective endocarditis is pretty rare. It's estimated that it affects some 3 to 10 people for every 100,000. But in developing countries where it may be more common, rheumatic heart disease is the leading risk factor. In the U.S., some of the major risk factors include heart valve disease, history of heart valve surgery, congenital heart disease, previous case of IE, or potentially intravenous drug use. It's no wonder, therefore, that the valves are very vulnerable to infection. They don't get a direct blood supply, so whether you have a native heart valve or a prosthetic valve, you have a harder time of massing that defense to ward off bacterial infection. Because prosthetic heart valves are more susceptible to bacterial infection, it stands to reason that patients that have them are commonly affected by IE, as are older populations. Even so, people of various ages can have the condition. Symptoms of infective endocarditis are not always clear or straightforward, but might be suspected of a patient with infection of an unknown origin, fever, heart murmur due to regurgitation and arterial obstruction, or potentially from complications such as heart failure, embolic stroke, paravalvular abscess, and valvular injury could be there as well. And depending on which side of the heart is more affected, different forms of embolism could be present also. On this next page, we have some other signs and symptoms from the American Heart Association. I won't name these all, but they're more of the overarching potential signs someone might come in with, especially for acute IE or sudden onset versus chronic. And these include a fever, chills, rapid heartbeat, sweating, and achy joints. A few more notable characteristics about this condition that you could look for are some physical symptoms, and these include splinter hemorrhages, Janeway lesions, and these ossular nodes, which are tender little purple lesions on the skin. Furthermore, you could possibly see Ross spots, which are going to be on the retina and would have a reddish yellow color. And you can see some of these in the pictures to the right. The two lists we have on this next page are a part of what is called the Modified Duke criteria, and this is used by people in a medical setting essentially as a checklist to identify those main initial symptoms, and once they get a blood culture, to know what to look for. Once you've gathered all your evidence about potential symptoms, you would need to take a blood culture to find out what, if any, bacteria are currently in the heart, and also to get an echocardiogram to gauge the health and the efficiency of the heart. In the pictures provided from B to D, we can see what an echocardiogram of a heart with endocarditis looks like. Now we will move on to treatments. Once infective endocarditis has been diagnosed, they will assess the patient's blood cultures and severity of condition, and may decide that the person needs to be admitted to the hospital. But from diagnosis, two main routes will be used for treatment, and those are antibiotic therapy or surgery. As far as antibiotics go, selection of the proper one largely depends on whether the patient has a native or a prosthetic valve, where the treatment is being provided, their severity of condition, and susceptibility to disease and infection. If they do need an antibiotic, often the ones used for native heart valve are vancomycin and ceftriaxone, and for prosthetic, they would use vancomycin and gentamicin. As far as surgery goes, an IE diagnosis may require surgery to replace the failing valves or to prevent an arterial clot. Timeliness in consulting with specialists is key here. Interestingly, some studies suggest there is a correlation between early valvular surgery compared to medical therapy and reduced risk of death for patients with heart failure and native valve bacterial endocarditis. In an effort to prevent the occurrence of infective endocarditis, the American Heart Association recommends that people at increased risk take preventive measures, including being aware of their own individual risks, such as any current conditions they have or a history of health complications, and to also consider antibiotics before certain surgical, medical, or dental procedures. In addition to the prevention guidelines from the AHA, I would also note that the prophylactic antibiotic recommendation does not apply to all patients for all types of procedures. It depends on a lot of different factors, and you would probably want to consult your healthcare provider. And just as a side note, the reminder that the greatest risk factors for infective endocarditis, according to the AHA, include congenital heart defects in children, young adults, and adults, previous valve surgeries or heart transplant, calcium deposits in mitral or aortic valves, history of endocarditis, and IV drug use. Now we will take a look at what effect bacterial endocarditis can have on the eyes and how an optometrist might be involved in spotting this person's symptoms or helping them manage their health care. Infective endocarditis can have a wide range of effects on the body, many of which coincide with those factors relating to the heart. But they can ultimately affect a lot of other organ systems, and that includes the visual system. Ocular symptoms of IE are especially pronounced if there is a sizable blocked retinal vessel located near the fovea. The fovea is the most visually sensitive area of the retina. Visual defects are usually only seen when there's a large occlusion or an infection is present. In the bottom left corner of the page, we can see what is called cotton wool spots on the retina. These are these whitish or yellowish glowing spots that result from microinfarctions on the retina. For any signs of IE that are going to occur in the eye, some of the most prominent are going to include retinal hemorrhages or vessel ruptures, retinal infarctions, those cotton wool spots that we talked about, Ross spots, which are the red hemorrhage spots with the light center, and conjunctival hemorrhage. In the pictures on this page, we see some really good examples of a Ross spot as well as some conjunctival hemorrhages. It's estimated that Ross spots and conjunctival hemorrhages account for some 2% to 5% of those with infective endocarditis, but on the whole, ocular symptoms just don't seem to be as well documented as some others in the literature. Even so, we have case reports that show that blurry vision, reduced visual acuity, choroidal neovascularization, retinal lesions, and occlusions have all been found in instances of IE. And these symptoms can show up either in initial presentation or after surgery. In one case report that I read, besides fever, visual reduction was the only symptom that the person presented with, and it turned out that they did have infective endocarditis. So it just goes to show you that whether someone has a seemingly minute or atypical symptom, it's always worth investigating. Now that we've looked at the pathophysiology, the etiology, how we might treat infective endocarditis, and now we've looked at how it would affect the eye, I think it's safe to say that The main thing to remember is that this condition comes in all shapes and sizes, in all ages, in various health conditions, and the main thing is that you're always looking at even the smallest to the biggest symptoms. As optometrists, we have the opportunity to be some patients' first line of health care. Thus, it's important that we can recognize pathology and then know how to address it proactively.